Welcome to an educational webinar from the Epilepsy Foundation titled Know Your Epilepsy. We're so glad you've joined us for tonight's learning. I'd like to share with everyone the mission of the Epilepsy Foundation, which is to lead the fight to overcome the challenges of living with epilepsy and to accelerate therapies to stop seizures, find cures, and save lives. I'd like to review with you the format for tonight's webinar. During the speaker presentations, all phone lines will be muted. We want to encourage everyone to submit their questions at any time during the webinar, and to do so, you can type your questions into the question window on the GoToWebinar panel and click Send. We'll read your questions aloud during the question and answer portion of tonight's webinar. Try to keep your questions general in nature, as the webinar is intended for educational purposes and does not take the place of individual medical advice. This webinar will be recorded and available for viewing and listening on epilepsy.com. My name is Dr. Elaine Kiriakopoulos, and it's my pleasure to be here with you this evening and to be joined by my colleague, Allison Kukla, who is a National Epilepsy Foundation Programs Manager, a member of the leadership team for the Epilepsy Learning Healthcare System, as well as serving on the Professional Advisory Board of the Epilepsy Foundation of Virginia. Thanks so much for being here, Allison.
Thanks, Elaine. It's great to be with everyone tonight.
We're so pleased to also have with us this evening our panelists Kate Cooper and Priscilla Covey, who will share with you insights and learning from their epilepsy journeys. Kate Cooper is the founder of Language Arts, which creates website content and other brand messaging for businesses. She's a mom, a designer, and a strategist. Her daughter Virginia, who is 16, was diagnosed with epilepsy 15 years ago. Thanks for being here, Kate. Priscilla Covey is a cancer survivor and has been living with epilepsy for 17 years. She obtained her Bachelor of Science in Biology from the University of Maryland, Eastern Shore, her first Master's in Molecular and Cell Biology from the University of Delaware, and her second Master's in Clinical Research Administration from the George Washington University, graduating with honors from all three institutions. She's co-authored several publications. She has always had an interest in the sciences, therefore not allowing her conditions to prevent her from pursuing a graduate education. Prior to her current appointment at the Epilepsy Foundation, she worked as a research assistant at the Howard Hughes Medical Institute. As a member of the Epilepsy Foundation's Research and New Therapies Department, her work contributes to the development of new drugs and therapies which aim to improve treatment options and quality of life for all patients. Welcome, Priscilla.
Thank you for having me.
There are no disclosures for tonight's presentation. Let's go ahead and get started with tonight's learning. Recognizing, as you listen, that epilepsy is unique to each individual and each family. Epilepsy journeys will vary from person to person and family to family, but there are some common things to know, and being informed and engaged can help to ease your journey. Tonight, we plan to share with you information that will help you to better understand your diagnosis of epilepsy and help you in explaining to others what types of seizures you have. We aim to provide you with information to assist you with managing medications, schedules, and behaviors to help you avoid seizure triggers. We also want to encourage anyone living with uncontrolled seizures to take that important step of requesting referral to an epilepsy specialist. And finally, we're going to present to you the basics of seizure first aid so that you can learn about seizure first aid and to help you educate others about how to respond if you were to have a seizure. We'll start off with the very basics of seizures. The human brain is an incredibly complex and dynamic structure, and it's made up of billions of cells called neurons. These neurons communicate with each other by sending and receiving messages in the form of electrical impulses and neurochemical signals. The electrical activity in the brain is normally very carefully balanced, and seizures occur when there's abnormal and excessive electrical activity that temporarily disrupts brain function. When we talk to patients about seizures, we often tell them to think of seizures as an electrical storm that's happening in the brain. Every brain has the potential to seize. Seizures are incredibly common. 1 in 10 people will have a seizure at some point in their lifetime. However, not everyone who has a seizure has epilepsy. As Jess mentioned, not everyone who's had a seizure has epilepsy. It's very important to make the distinction between seizures and epilepsy, and also to make a distinction between seizures and mimics of seizures, events that may appear outwardly similar to a seizure. A careful and methodical evaluation of the individual event, the possible seizure, is critical because sometimes movement or behavior that looks like a seizure can make a diagnosis difficult. Seizures or seizure-like activity can be caused by certain medical conditions, psychological conditions, or even by certain medications. And in those instances, whatever medical cause or psychological cause is determined, treatment options are available. You can see from this flowchart, when a person presents with an event that is described as a possible seizure, all potential causes for the event must be considered, and depending on the description of the event, the medical history and the examination of the person, and testing that's completed, the likelihood of a seizure is carefully considered. So why should we bother to figure out if an event was a seizure? This graphic makes quite obvious the importance of carefully evaluating someone who's had an event concerning for a seizure, because as you can see, the appropriate and most effective treatment will differ considerably depending on the cause of the event. And treatment, we know, is important to lower risks that are associated with seizures or other events which mimic seizures. The next question, naturally, is when does a seizure or seizures lead to a diagnosis of epilepsy? We've just discussed that any person has the potential to experience a seizure, but when is a person diagnosed with epilepsy? A diagnosis of epilepsy indicates that an individual is at increased risk for having recurrent or more seizures. More formally, the diagnosis is made when someone has 2 unprovoked seizures occurring greater than 24 hours apart, or if a person has 1 seizure with a high chance of having another. So if someone were to have 1 seizure and their testing demonstrated an abnormality, for example, a structural lesion on an MRI scan or some type of brain imaging, or abnormal brain waves on an EEG, that person might still receive a diagnosis of epilepsy because of a likelihood or increased risk they have for recurrent seizures. The definition of epilepsy also includes that if a person has been diagnosed with a syndrome that includes seizures, even if they've only had 1 seizure, that person may still be diagnosed formally with epilepsy. A diagnosis of epilepsy does not indicate the cause or the prognosis. Epilepsy is multifactorial, multifaceted, and varies in severity from individual to individual. There are many different types of epilepsy. We know that anyone can be affected by epilepsy, no matter age, race, socioeconomic status, or geography. Anyone can have epilepsy. Epilepsy can be described as a spectrum disorder. We know that children who are younger than age 2 years and adults older than age 65 are more likely to be diagnosed with epilepsy because of risk factors that are more common in these age groups. It's important to understand that there are many different risks and causes when it comes to epilepsy. For many people diagnosed with epilepsy, the underlying cause is unknown. And when a cause can be identified, some of the common causes include brain trauma, brain lesions, for example, a brain tumor, infections which target the brain and the coverings of the brain, a brain injury at birth, abnormal brain development, or stroke. With advances in brain imaging and genomic sequencing, this is leading to more people having a better understanding of their epilepsy. If we take a moment to look at some of the numbers associated with epilepsy, we know that approximately 3.5 million Americans live with active epilepsy, that 65 million people worldwide are impacted, and that 1 in 26 people will be diagnosed with epilepsy during their lifetime. Let's talk a little bit about types of seizures. Seizures are the main symptom of epilepsy, so let's review how a seizure might present or what a seizure might look like to an observer. For most people, when they hear the word seizure, it conjures up the image of a person who is collapsed and is unaware of their surroundings, lying on the ground with shaking and jerking movements. Now, this is one type of seizure often portrayed in our media and films or on television, but it's not the way that all seizures present. Seizures can present many different ways. A seizure can be a staring spell. It can affect one part of the body with a less obvious movement, like a muscle twitch or a change in muscle tone similar to a spasm. A seizure can present as someone being confused or having difficulty moving or speaking, or as someone wandering. There are some seizures that have very few outward signs and can be as subtle as a funny tingling sensation that someone has or an unusual smell that they experience. And these seizures are often difficult for anyone but the person experiencing them to detect them. And for many people, be it the person having the seizure or a loved one witnessing the event, and even for practitioners, the variability with which seizures present can sometimes make it hard to diagnose epilepsy. Another thing to highlight is that seizure symptoms and signs of seizures will vary from person to person. A very common sentiment that neurologists share with their medical students and resident trainees is that when you've seen one person with epilepsy, you have seen one person with epilepsy. Every person is different. However, in most cases for any one individual, the symptoms and signs of their seizures are stereotyped and can be described as usually consistent and predictable. Let's spend some time reviewing the different types of seizures. And we're going to break this down very simply into three main types of seizures for the purposes of today's discussion. A key to defining the type of seizure a person has is where the seizure begins. And this is sometimes referred to as the area of seizure onset or the seizure focus. The brain, as we know, is divided into two halves called hemispheres. Focal onset seizures begin in and involve only one hemisphere of the brain or less. Generalized seizures have their onset in both hemispheres of the brain, and we think that seizures that involve both hemispheres of the brain probably occur from deep pacemaker areas of the brain that fan out all at once, or that there are possibly networks of brain cells that synchronize so quickly that we're not able to determine where they begin. And when it's not possible to determine where a seizure begins, those seizures are classified as unknown. Often, with time and more extensive testing, Unknown seizures can eventually be better defined as having either a focal or generalized onset. Another key factor in classifying the type of seizure someone has is whether or not the person's level of awareness is affected during the seizure. And this is very important in how we classify focal seizures in particular. For generalized seizures, where both hemispheres of the brain are involved, of course we would expect then that a person's awareness would be impacted. The other information that is considered when classifying seizures is whether or not the seizure involves other symptoms, such as a person's face or body having movement during the seizure. You will see on the next slide how we use motor symptoms to help us further classify the type of seizure someone is having. So this diagram is a schematic of the classification developed in 2016 and published in 2017 by the International League Against Epilepsy. You can see how the information we discussed on the prior slide fits into the classification scheme here, which highlights that seizures are classified by their onset or where they start, focal or generalized, how they impact a person's awareness, and whether or not someone has motor symptoms that accompany the seizure. So if we take a look at the first column, focal seizures, they can present with or without a person's awareness being affected. And they can also have motor symptoms that accompany them or not. I want to point out here that any seizure that starts in one area of the brain can potentially spread to involve both hemispheres. And this is referred to as a focal to bilateral tonic-clonic seizure, which people sometimes use older terms like grand mal or convulsion to describe. Under the second column are generalized onset seizures, which we know present with impaired awareness because the entire brain is impacted. And this type can have a variety of motor symptoms. There are also generalized seizures called absence seizures, which are classified as non-motor. And an old term that you might hear to describe these is petit mal. And these seizures tend to cause a lapse in awareness that can include symptoms of staring or a blank expression. You might be asking, why is it so important to classify a seizure? Classifying a seizure is important because it helps to determine the best evaluation for a person to have, and it helps medical teams determine what are the most appropriate treatment options to consider. It will also help you to understand how to best apply the basic principles of seizure first aid. Let's move on to consider diagnosis and treatment in epilepsy. No single test is used to diagnose epilepsy. And the diagnosis of epilepsy is, of course, something that's made by a medical professional. Critical information to help diagnose epilepsy is the medical history of the person and a description of the events that are concerning for seizures that took place. It's common for an evaluation for epilepsy to include reviewing complete medical and neurologic exams, for there to be blood tests and brain imaging, and an EEG test, an electroencephalogram, to record the brain's electrical activity. Sometimes it's necessary to obtain a more extended EEG, and this can be done as an outpatient or an inpatient. We talked about on the previous slide the importance of sharing a person's medical history and a description of the event with the medical team, and just how critical this can be to helping sort out the diagnosis. One way to think about things you are observing is to break things down to what you saw early during the event. So what did you first see or hear? Was the person able to tell you they felt unwell or that a seizure might be coming? Next, what did you notice during the seizure? Was the person awake? Were they confused? Were they conscious or were they not conscious? What part of the face and body was involved? Did you notice any unusual speech or behavior problems? And then finally, what happened after the seizure? How long did the seizure last? Did the person return to their usual state quickly, or did it take a long time for them to get back to their baseline? Was the person confused, or did they have other symptoms after the seizure? These types of observations can be very helpful to a medical provider. I will share with you briefly so you have a general awareness that there are a number of different options for treating epilepsy, and we'll review those quickly tonight. The most common treatment method is anti-seizure medication, and you might hear this also referred to as anti-epileptic drugs or the short form AEDs, or also people routinely use the word anticonvulsants. The ever-present goal of therapy in epilepsy is, of course, to stop seizures, and to do this with a treatment that has the least amount of side effect possible, and ideally no side effects, although that's really difficult to achieve. We know that anti-seizure medicines work by suppressing the symptom of epilepsy, seizures. They do not treat the underlying cause of epilepsy or cure epilepsy, but simply work by stopping the abnormal electrical activity in the brain that gives rise to a seizure. Clinical studies have helped us to better understand how effective medications are at preventing seizures. We know that for about 2 out of 3 patients, it's possible to achieve good seizure control with medications. And for this group of people, their epilepsy can generally be described as uncomplicated. But for about 1 out of 3 people, anti-seizure medication is not able to control their seizures. And for this group, epilepsy can sometimes be disabling. Frequent and unpredictable seizures bring risks, and they interfere with day-to-day life. And medication side effects can limit learning, employment, and for many, the presence of ongoing seizure activity in the brain can have long-term effects as well. I do want to spend a brief moment going over the term drug-resistant or medication-resistant epilepsy with you. Drug-resistant epilepsy occurs when there's been a failure of adequate trials of 2 tolerated and appropriately chosen and used anti-seizure medication schedules to achieve sustained seizure freedom. So simply put, a trial of 2 medicines that the person taking has been able to tolerate, that the medications were chosen appropriately for the type of seizures that they have, and that the person used the medicine the way it was prescribed. If someone is drug resistant, this should prompt a referral for comprehensive review of the diagnosis and management. And preferably, this should be done by an epilepsy specialist at an epilepsy center. Now, we know there are a number of factors that can contribute to treatment failure in epilepsy, and this list includes poor adherence to medication or other therapies, poor sleep, so poor sleep quality or not enough sleep can be a problem, active medical illness and high fever, major emotional stress, hormonal changes. The period of medication adjustments can be particularly tricky, and often people will experience seizures as they're switching from one medication to another or titrating medications. And substance abuse can also contribute to treatment failure. So what are some of the important things to know about your medications? So you definitely want to know the name of your medication, the dose that you're taking, and the formulation, meaning is it a generic or a brand name medicine? And that's going to be a discussion you want to have with your physician and also with your pharmacist, so that when you pick up your prescription, you're getting the right medicine. You want to have a careful review of your dosing schedule with your epilepsy doctor or nurse. You want to be aware of any potential side effects that could come from the medicine, any drug interactions. You want to know how the drug is metabolized. Is it something that involves metabolism with the liver or with the kidneys? If you're planning on pregnancy, you're going to want to know about the safety testing for the drug in pregnancy. And it's always good to speak in advance with your provider if you're thinking of becoming pregnant. If you're able to do so, to plan ahead, it's always better to do that, to let them know that you're thinking about a pregnancy. And then you can discuss your medicine and plan for what might be the best way to keep you and your baby safe during the pregnancy. You'll want to ask about adjustments in dose for younger children, for older adults, and for someone who may have a specific illness. For example, for someone who has kidney failure, they may want to know if there needs to be an adjustment of the medication, if that medication passes through the kidneys to be metabolized. And finally, you'll want to have a discussion about insurance coverage and cost to make sure that when you leave your medical provider's office, you're able to go and pick up that medicine and take it home and use it as it was prescribed. Along with anti-seizure medicines, there are other treatment options for epilepsy that exist. And this includes epilepsy surgery. And there are many different types of epilepsy surgery and surgery techniques that range from open procedures to remove the area of brain tissue that's responsible for seizures, to using a laser to target the abnormal area that is the seizure focus. Medically prescribed diets, the ketogenic diet is what many people have knowledge of, can be used in infants and children and adults. And this is a field of epilepsy therapy that has made good progress over the last decade and continues to evolve as a treatment option. So it's something to ask your doctor about if you're interested in a medically prescribed diet. Neuromodulation with implanted stimulation devices is frequently used in patients who have not responded to medications. And these devices have the ability to stimulate outside the brain, so a nerve outside the brain, the vagus nerve in the neck, or to directly stimulate brain tissue in the case of responsive neurostimulation or deep brain stimulation. Investigational medications, so medicines being studied in clinical trials, can also be considered if other modalities of treatment have not been successful. And finally, seizure trigger management is also a key intervention. And Allison will be sharing with you more about seizure triggers shortly. I want to spend a little bit more time sharing with you more around the treatment option of surgery. So studies have demonstrated that in general, people are not being referred to epilepsy centers in a timely manner for surgical treatment, and that a number of factors contribute to this. One factor is that often epilepsy surgery is perceived incorrectly as a last resort. Another is that the risks of ongoing seizures are underestimated, but we know that uncontrolled seizures can carry tremendous risk medically, psychosocially, and for quality of life. Another problem has been that the outcome of medical therapy in drug-resistant or refractory epilepsy is overestimated. We know, based on the current definition of drug-resistant epilepsy, which we just reviewed, that after a trial of 2 medications not working, it's time to move on to a specialized evaluation and begin to explore other treatment options. This can't be emphasized enough, because we know continuing to add medicines or switch medicines simply does not bring the good results that some of the other treatment options can provide. So we want to get people to those other options and to those evaluations for those other therapies sooner so that they can hopefully find seizure control and have better health outcomes and quality of life. Another issue has been that the risks related to surgery are overestimated. With new diagnostic and with minimally invasive techniques, surgery presents a good option for many people. So if you're someone who had an evaluation for surgery 10 or 20 or more years ago than that, and you're still living with uncontrolled seizures, talk to your doctor. Ask them about a reevaluation now in 2020. Things have changed, and there have been advances both in diagnostic evaluations and surgical options. I want to share with you some of the data we have around epilepsy surgery being underutilized. We know that less than 1% of people with drug-resistant epilepsy are referred to epilepsy centers. This is an extremely low and concerning number. We also know that there are between 100,000 and 200,000 people in the United States who are considered eligible for surgery. But the numbers show that only 2,000 to 3,000 surgical procedures are done annually. The other problem around this is that these surgeries often happen late, typically many years after the onset of uncontrolled seizures. And of course, this affects both health and social outcomes. So again, if you're a person with uncontrolled seizures, talk to your doctor and ask about options. If they don't have answers for you, request referral to a provider with epilepsy training who may be able to help you. And with that, I'm going to turn things over to my colleague, Allison Kukla. Allison, thanks so much.
Thanks, Elaine. So now let's talk about triggers. What is a seizure trigger? A trigger is something that occurs consistently and more often than by chance. They include behaviors or situations that increase the likelihood a person will have a seizure. Some people are able to identify triggers, whereas others are not. Keeping track of when your seizures occur and what was happening around that time can help you identify possible triggers. Recognizing the most common trigger for seizures is missed medications. It's important to work with your healthcare team to come up with strategies to avoid missing medications. So what are some common triggers? Triggers people often report include poor sleep or lack of sleep, stress. And stress is something people have discussed for years, and for many years it was often dismissed by practitioners, but is now being better recognized that both negative and positive stress may be a trigger for individuals. Alcohol or drug use can also be a trigger. For some individuals who have generalized epilepsy syndromes, they can be very sensitive to alcohol use, and that makes them more likely to have seizures. Hormonal changes are also a well-known trigger. There are women who have seizures at certain times in relation to their menstrual cycle. For some people, when they are sick, seizures can be more likely to occur. It is always important to let your providers know if you have an illness that keeps you from being able to keep your medication in your system. For example, if you're vomiting up your meds, they may need to help you come up with another plan for keeping you seizure-free during this time. It is also important to let your providers know if you have been prescribed an antibiotic to treat another illness, so they can share with you if the medication may interfere with your seizure medication. For a small percentage of individuals, flashing lights can also be a trigger, and some prescribed over-the-counter or herbal medication can trigger seizures for some people. You should always talk to your healthcare team when thinking about taking other medications of any kind. So let's talk a bit about why it's important to identify these triggers. To begin with, knowing the triggers can help you recognize when you might be at high risk for a seizure. For example, if you're sick, or if you have a fever, or if you've gotten a poor night's sleep. It also helps you plan around avoiding triggers, and it helps you prepare to deal with a trigger. For example, this might be your doctor adjusting your medication in the setting of an illness or using a rescue medication. And as we said earlier, the most common cause is missing medication. So again, it's very important to come up with strategies so you don't miss medications. Also, by identifying your seizures, you can explain to friends and family you may need to avoid a behavior or a situation. Let's talk briefly about reflex epilepsies. Some individuals have what's referred to as reflex epilepsy, and these are seizures caused by specific sensory inputs. Keep in mind, this is not everybody, but there are certain individuals that have these as common seizure triggers. One we have already mentioned is flashing or flickering lights. For some people, it's geometric patterns. For some individuals, certain types of music or even a specific pitch might be a trigger. And for others, reading or doing math calculations. Loud noises or unexpected touch that are startling are also sensory inputs, can cause seizures in individuals who, again, have reflex epilepsy. So it would be important for those individuals to avoid these sensory inputs when possible. Identifying your seizure triggers are important. Some ways to help identify those is keeping a seizure diary. It may sound silly, but I'm sure a lot of people do keep seizure diaries, and it's really important. Keeping a diary can be done in many ways, by writing notes in a paper journal or an online journal, or using an electronic tool to help track your seizures. You want to use your journal to keep track of seizures and also other events that are going on that day. Ask yourself, for those who were with you, what were you doing at the time? Were you up late? Were you excited about something? Did you drink too much? Was there weird lighting, noises? Any of those possible triggers that we just went over to see if that was happening at the time you had a seizure. And you want to share these notes and your diary observations with your doctor. So now that you've identified seizure triggers, what can you do? Speak to your doctor about taking action if that is what is needed. It can be tough to change behaviors, but once you find a step that works for you, you can take and prevent a seizure to try to do the best that you can. You also want to turn to the people who are closest to you and care about you. Enlist your family and friends and have them help you avoid being exposed to your triggers. Alcohol use, for example, is common in our culture, and therefore many individuals, there's a lot of pressure to drink. If you're an individual whose seizures are caused by alcohol, you're going to need to work with your family and friends, particularly if you're around people who like to drink, who may want to have you drink with them. It's important for those individuals to recognize that drinking alcohol is something you would need to avoid. Support from your family and friends is very important in avoiding these triggers. Epilepsy centers are where you can receive specialized care to manage your epilepsy, and they are found all over the country. Epilepsy centers are accredited through the National Association of Epilepsy Centers, or NAEC. Accreditation helps to ensure that an epilepsy center meets certain criteria so that they deliver expert level care. Epilepsy centers provide both outpatient and inpatient comprehensive care, and epilepsy specialists are experts in the diagnosis, evaluation, and treatment of epilepsy. You can find an epilepsy center near you by going to epilepsy.com or going directly to NAEC's website. Epilepsy teams are multidisciplinary teams that meet the requirements of NAEC. They are a coordinated team of experts in both adult and pediatric epilepsy care. You can see from the list here, it includes a variety of providers to offer you the best care when treating your epilepsy. There's morbidity and mortality associated with epilepsy, and we know this is more worrisome when seizures are not controlled. Up to a third of people with epilepsy are more likely to have accidental injuries related to their seizures when that's compared to the general population. Up to 20% of people with epilepsy will have an episode of what's called status epilepticus, a seizure emergency, and that's when a seizure is longer than 5 minutes, or when seizures occur close together or back to back, and there's not a recovery of consciousness or awareness between the seizures. People with epilepsy also need to be aware of SUDEP, which is sudden unexpected death in epilepsy. Each year, about 1 in 1,000 people with epilepsy die from SUDEP, and we know that this number increases significantly to about 1 in 150 people whose seizures are not controlled. Risks of SUDEP include uncontrolled seizures and generalized tonic-clonic seizures, as well as seizures which happen at night. Uncontrolled seizures can also have social, emotional, and financial impact. Earlier tonight, you heard Dr. Kiriakopoulos encourage that if someone is continuing to have seizures despite treatment, that they should consider and ask for referral and evaluation from an epilepsy specialist. And I'd like to ask the same of everyone listening. The risks are known and they are high, so please take action. Communicating with your doctor is important in getting the best care possible. Here are some tips on how to start. You want to ask for your doctor's contact information and their preferred method of communication, which could be through a MyChart portal. You want to prepare a list of questions before your appointment so you can get the answers that you need. It's always good to bring a close friend or family member with you and ask them to take notes, since appointments, there's a lot of information being shared. You should learn how to access your medical records to keep track of test results, your diagnosis, treatment plans, and your medications. And remember, your nurse and pharmacist are also a really good source of information and resources for you. It's your decision if you share with others about your epilepsy. When you share, it's important to be prepared, and here are some tips. Think about who needs to know about your epilepsy. What is important to share with them? Consider when and why you are telling them, and prepare for their response to you sharing about your epilepsy, which is important health information. One thing that is important to share is seizure first aid. Share it with your family, your friends. Let's review it together tonight so you can share it with others. Let's walk through what you can do if you happen to be present when someone is having a seizure. You now know there are many different types of seizures, and clearly you'll need to tailor your response appropriately, but there are some common principles that apply. 3 important words to remember in seizure first aid are stay, safe, and side. Timing a seizure is also important, and we want to keep the number 5 minutes in mind as well. Okay, let's walk through this chart here together. Step 1. If you are present when a person is experiencing a seizure, you want to stay with that person. If the person is having a general convulsion, it can be pretty scary to watch if you've never seen one before. But it's important to remain calm and to try to keep those around you calm. Check for a medical ID and use your watch or phone to begin timing the seizure. Step 2, you're going to want to keep the person safe. You should move harmful, sharp, or hard objects out of the way, and if the person wanders with their seizure, try to gently guide them away from any dangerous situations, like traffic or terrain that is rocky or uneven. If the person loses consciousness, gently guide them to the floor or ground if you can. Step 3, turn the person onto their side. This helps to make sure they don't choke on their saliva, and it helps keep the airway open. You can put something soft like a jacket or sweatshirt under their head, and loose and tight clothing like ties or scarves that may be around their neck. Step 4, never put anything in their mouth. You should not offer food or medication to a person who is not completely awake and aware. Step 5, you never want to restrain a person during a seizure. Holding someone down during a seizure does not stop movements that accompany a seizure. The movements will stop when the seizure ends, and most seizures last between several seconds and a few minutes. Step 6, after the seizure ends, you should stay with the person until they are fully alert and aware. Offer reassuring words and let them know in simple terms what happened and that they are okay. Remember, they'll be very confused when they wake up. You can offer to call a loved one to help them return home safely. Most seizures are not medical emergencies, but there are instances where 911 should be called. These include if a seizure lasts longer than 5 minutes, if a person has repeated seizures, if there is difficulty with breathing, if the seizure occurs in water, if the person is injured during the seizure or is pregnant or is in medical distress, if a person does not return to their usual state after a seizure, or if this is a person's very first seizure. If you've called 911, when the paramedics arrive, you're going to want to share information about how long the seizure lasted and a description of what you've noticed during the seizure. And at this time, I'm going to turn things over to Elaine, Priscilla, and Kate.
Thanks so much, Allison. That was a great review of triggers and communication with your epilepsy team, as well as your review of seizure first aid. That was very helpful. Thanks so much. And so we're going to turn to our panelists now who have graciously and kindly offered to share with us their insights about their epilepsy journeys and what they've learned along the way. Priscilla, are you there? Are you with us?
Yep, I am here. Can you all hear me?
We sure can. Thank you so much again for being here tonight. And I wonder if we could start by you sharing a little bit about you and your family for everyone.
Yep. So my name is Priscilla. I was born in Ghana, West Africa, and the picture on the left side of the screen is me and my older brother. I moved to the United States around the age of 5, and the picture in the middle is my husband and my puppy that's been with me for the past 7 years. He's seen me have plenty of seizures, so he kind of knows what to do now. And the last picture is me last year in April at the EMU, having video EEG monitoring done. My family and I live in Columbia, Maryland, and I work at the Epilepsy Foundation. As you heard at the very beginning of this webinar, I have a big interest in science, and that's why I pursued science in college and as well as in graduate school.
Great. Thanks so much for sharing with us, Priscilla. And your pictures are gorgeous. Your puppy looks adorable. So cute.
Thank you.
Can you share with us your perspective on receiving a new diagnosis of epilepsy?
Yes, so receiving a new diagnosis was a huge relief for me. I had my first seizure at the age of 11, and I believe I had symptoms before I had my first tonic-clonic episode, but it was pretty scary because I was kind of fully aware that something was wrong. I remember my eyes rolling back into my head, and it was very painful. And when I woke up, I had fallen on an old school projector. I don't know if anybody was born in the 80s or the 90s, but the old school projectors were pretty large. So they sat on a cart, and I fell on the cart and had a huge knot on my head. And I also had peed on myself. And this all happened in middle school in math class. So that was pretty scary because I didn't know what my classmates were going to think of me when I came back to school. My mother was also pretty scared because that wasn't the only seizure I had that day. I had another seizure about an hour after I left the emergency room. So that's when the doctors, figured that there was something more going on and it just wasn't an anomaly that happened. So they referred me to a neurologist, and after having a few exams done, they diagnosed me with generalized tonic-clonic seizures with aura. and also figured that I had photosensitivity. And from that point on, I kind of felt like I, didn't completely know what to do, but I kind of felt like we had a step in the right direction and that we could, find a solution to resolve this so that I could return to school and be around my friends.
Sure. And, middle school, high school, that's a tough time for a kid anyway. There's lots going
Yep.
on, both academically and socially. What did you
Yep.
find was the hardest for you as a teenager being diagnosed with epilepsy?
I think the hardest thing for me was being able to explain my diagnosis to my friends and my classmates and not being judged. I also found that adhering to my medicine was really hard for me because I just did not want to take meds. It was, something I had never done before, and all of a sudden I'm required to take medicine multiple times a day, and which required me to go to a nurse's office at least once a day. And even on school field trips, I always had to get pulled to the side to take my meds. So, it was a little bit difficult for me to accept that this change had happened and that, sharing my diagnosis with people was important, and also not to be embarrassed about my diagnosis. And the first time I was ever bullied was when I went to college and I had my first seizure in my dorm room, where my roommate said she no longer wanted to be roommates with me. And it really did hurt my feelings. The institution I went to did not want me to be there. They initially refused my attendance because I listed that I had epilepsy on my enrollment form. So that was like something that made it really difficult for me as a young adult and as a teenager.
I'm sure. I'm sorry to hear about those struggles. Sounds really like a very difficult thing to have to go through. Can you share a little bit about what resources have been helpful to you in learning more about seizures and epilepsy?
So I found that articles that I found on the web, especially articles from the Epilepsy Foundation, were really helpful because I needed to understand my type of seizures. And although my doctors, would do a good job during my visits, sometimes at home I would be experiencing something different that I wasn't sure if it had anything to do with my medications or if it was just part of having the condition. So I found that those articles on epilepsy.com that just gave a general overview of what epilepsy is, the different types of epilepsy, why adhering to your medication is important. Even seizure first aid was really helpful for me because I was able to relay those messages to my close friends and family. I also found that my visit to the neurologist's office was really helpful when I did come in with tailored questions for my doctor so that my visits were impactful, and also pointing out my concerns regarding my medicines if I was experiencing any side effects. And all that information I learned by doing some online research and also communicating directly with my physician.
Great. And one last question, can you share what value an epilepsy center evaluation has brought to your treatment?
So the value that going to an epilepsy center has impacted my life is that my husband now understands my condition a lot better because he stayed with me during my EMU stay. Additionally, understanding that I'm actually not, they just told me that I'm actually not sleeping. So I never get to REM stage. So I'm constantly sleep deprived. And that explains why I have absence, why I experience more absence, or why I'm not necessarily well controlled with my epilepsy because I'm just not sleeping. So having that knowledge is really helpful for me because now my doctor and I are trying to troubleshoot what we can do to help me get to REM sleep so that I'm rested. And as Elaine pointed out earlier, sleep deprivation is a trigger for many people, and I am one of those people that sleep deprivation is a trigger for me. So being at the EMU really shed a light on that. I don't think I would have ever known that if I never did that today.
Great. Priscilla, I want to thank you for sharing your insights with us this evening and for joining us. And I want to thank you for all the work you do at the Epilepsy Foundation to help other individuals and families, and for your fierce advocacy and for lending us your brilliant scientific mind. Thanks for all you do.
Thank you very much for having me.
Kate, are you on the line?
I am.
Great. So Kate Cooper, welcome, and thank you for being here with us tonight. And I wonder if you could start by sharing with us a little bit about your family.
Sure. I think everybody's seeing a photo of them right now. My husband, Matt, and I have 3 children. Our oldest son, Ned, is a college student studying film. Our middle child is Virginia. She is 16, almost 17. She's a junior in high school and a competitive rock climber, and she has epilepsy. And our youngest son, Gilbert, is 13, and he's a wrestler and rugby player. My children tend to like risky sports, so they keep us on our toes.
You guys are definitely a busy bunch. So I'm wondering, Kate, if you'd be willing to share with us as a parent what it was like for you receiving a new diagnosis of epilepsy for your daughter, who was very young, at just 17 months, I believe, when she was diagnosed.
That's right. That's right. Yeah, I'm happy to. I knew absolutely nothing about epilepsy when Virginia had her first seizure. She was 17 months old, you're right, and it was August 2004. And she made a funny face while she was playing. It looked like a vomit reflex to me at first, and I scooped her up and ran to the bathroom with her, but she didn't get sick. And then I noticed she did it a few more times that day. I thought about it at night in bed and thought it was a little odd, and then I saw her do it again the next morning. And so I took her straight to the pediatrician. Our pediatrician was open on Saturday mornings, so we made a quick stop. And honestly, we got very, very lucky. It could sometimes take a very long time to get a diagnosis. As Priscilla was explaining, we got lucky and had a diagnosis within the day. At the pediatrician's office, Virginia had a seizure in front of the pediatrician. The pediatrician sent us to the ER. She had a seizure in front of a resident in the ER. They put her in the PICU. And when the neurologist came in to talk to her, she had a seizure in front of the neurologist. So very, very quickly, we knew that these were indeed seizures and that something was going on. So they kept her in the hospital for about 5 days. They were looking for the cause of the seizures, the things that you mentioned earlier, Elaine. So they were looking for a brain bleed or a tumor. And when they didn't find one, we honestly felt very lucky. You know, we sort of felt like we'd won the lottery. We thought, okay, epilepsy. We knew that most kids' seizures were treatable and that most kids outgrow it. So we had a real sense of relief, but over time it became clear that Virginia has drug-resistant epilepsy, which is something you mentioned earlier. And so it's been a struggle since then.
Sure. And can I ask what resources were most helpful to you in, it's been now 15, 16 years, right? So along the way
Yes.
and early on, what resources were most helpful to you in learning more about epilepsy and figuring out how your family would manage epilepsy from day to day? Because it obviously, when your child has epilepsy, it's something that, you know, influences the entire family.
It does. It does. Like Priscilla, I found the Epilepsy Foundation website extremely helpful. I also got a lot of great information from an organization called CURE. It stands for Citizens United Citizens United for Research in Epilepsy. And then from other parents and patients. Honestly, social media is a game changer when your child is struggling with something like this, or when you're struggling with something like this, and the ability to connect with patients and parents who could share really practical advice and helpful information, that has been invaluable to us. The epilepsy centers of excellence that have come up over and over tonight, a lot of them have great websites, great videos, great explanations of procedures and tests, which have helped us prepare ourselves and prepare our daughter for various hospital visits. So there's a lot of great information out there.
Great. can you sort of pinpoint any hurdles that were the hardest for you in becoming an informed parent?
Oh, that's an interesting question. I think the hardest thing in terms of an information hurdle has been knowing how hard to push sometimes, because there's so much information out there, and your doctor or epileptologist or neurologist, whoever you're seeing, is really your care partner. And so
Right.
knowing when to, defer to their expertise and knowing when to continue to push. And the way we got comfortable with that was to really choose healthcare providers who really treated us like partners too, because then it's not really pushing, it's having a conversation and really
Right.
talking through benefits and risks of everything you're considering. And when you're talking to each other that way and you have that mutual respect, everything feels very different.
Sure.
So that's been very important to us.
Absolutely. And you're obviously someone that has really taken action to inform yourself and empower yourself with knowledge as you engage in both health and quality of life decisions that are being, made for Virginia, both when she was younger and now as she's a teen. Can you share a little bit of perspective around that?
Sure, yeah. So being knowledgeable, doing all the reading that we've been talking about, understanding the basics really helps me ask better questions and be a better advocate for my child. So at that level, it's really important. It's also become very clear to me that I'm the most consistent member of her care team. So being knowledgeable is really important because I'm the one keeping track of everything. As you move from one center to another and have different tests, in the end, I'm the consistency. And so I really need to understand things. And being knowledgeable about the various treatment options, which, as you said, have come a long way recently. The technology is just getting better and better, and the tests are less and less invasive. And because I'm aware of them, I can really confidently either accept or challenge what somebody is suggesting to us. I can even bring up ideas that haven't come up before and have a conversation about them. And knowing about all that innovation and research that everyone has been mentioning tonight really helps us compare our options and, frankly, demand more on behalf of our child. I often feel that it's my responsibility as a parent to get a second opinion or to talk to somebody else. And because I'm knowledgeable, I know where to go to do that. Or if I don't have the knowledge, I reach out to my network of friends and find out where to go. So medical professionals can be kind of dismissive if you're a mom who has a content design agency, but it's really hard for people to dismiss you when you know what you're talking about. So the more you understand, the more powerful of an advocate you can be for your kid.
That's great advice, Kate, on all fronts. And how are you working, as a mom now, transitioning your daughter from being a tween to a teen and eventually a young adult? How are you helping Virginia get to know her epilepsy so that she can lower her risks as she gets older and so she can plan for things like college and living independently?
This is an ongoing struggle for us, especially, as you said, because she's a teenager now. So you have all the regular teenager stuff, and then you have someone who's having seizures. In our case, Virginia's seizures are in her frontal lobe, and that's where your executive function is. So it can be really hard for her to manage this completely on her own. So we are very open about the risks. Allison touched on a lot of those tonight about the risks of drowning, the risks of death. We talk about all that stuff very openly because she's nearly an adult. The risks of missing medication or being in the ocean without a life jacket. So we enforce those rules. We talk about those rules, and we enlist the help of her friends with her permission. We don't talk about it without her permission. And we are actively always seeking people who are just a little bit older than her to connect her with, people who can serve as role models. My daughter knows Allison and really looks up to her and gets great advice from Allison. I would like my daughter to know Priscilla and get advice from her. And then we're always looking for tools. Again, going back to technology, there's so much out there now, and not all of it is necessarily intended for epilepsy, but can be very powerful for epilepsy. Virginia struggles to remember to take her medication, and we found a system called the pill drill. And it works with these smart pill pods, and then an app that notifies me when she takes medicine or when she misses medicine. We have found an app called Streaks that encourages good habits by building streaks. You know, kids like Snapchat streaks. This uses that same kind of psychology to, again, help her remember to take her medicine. So we try things and we ask her what she likes and what she doesn't like, and we go from there.
Great. Well, let me ask you, you know, as a parent, obviously this is tough for Virginia, but it can also be tough for you as a mom. So what do you do for yourself to sort of keep your wellness going?
That's a good question. You know, you have to remember when you have a child with epilepsy, or I guess any other sort of situation like this, you know, there's really a marathon, not a sprint. And so it's super important that we take care of ourselves. So I try to get as much sleep as I can. That can be tricky with a kid who has seizures at night, but I do the best I can and try to ask for help from family and friends if I need someone to take her for the night. I run a lot. You'll see pictures in the slide here. There's a picture of me and Virginia running a 10K together. The picture in the upper right-hand corner is a run that we did to raise money for epilepsy. Allison was on my team. We did a 200-mile relay run. It brings me peace. It gives me space. And my husband and I make an effort to go out alone at least once a week without any kids around. And when I say go out, we're not doing anything super fancy. We might just walk down the street to have a beer. And when the kids were really little, we would honestly just sit on the front porch after they went to bed and be alone, you know, with a little change of scenery and have a beer and talk about things. And then since I have these two other children too, I try to make a concerted effort to spend a little bit of time with each one of them alone during the week, so that all the attention and focus isn't on this child who has this medical struggle, because, you know, every kid has a struggle. So I want to make sure they're getting the attention they deserve too.
Absolutely. Well, it sounds like you've employed some really good and healthy strategies to help you and your family. And I appreciate you sharing those insights with everyone. They're really valuable for people to hear about. And I'm going to invite Priscilla back to the conversation at this point as well, and ask each of you, because you're both passionate advocates for epilepsy and the families it affects. I want to thank you for all you do. How has advocacy played a part in your journey? So maybe Kate, if you want to share with us first, and then Priscilla, if I could ask you to share around advocacy, that would be great.
Yeah.
Sure, I'm happy to. Look, my daughter's had tens of thousands of seizures over 16 years, and there's not a lot I can control. Being an advocate on her behalf, on behalf of others, gives me some sense of control over this situation. When I'm in an EMU, which I've done over and over, I see people who don't speak English as a first language, don't have a job as flexible as mine. And I really want to advocate on their behalf as well. Not everybody has the luxury to do that. So I'm not just fighting for Virginia, I'm fighting for lots of other people. And then purely selfishly, advocacy has brought great people into my life. And so it's a big part of my journey because it also keeps doing great things for me. I meet new people, I find new information. So while it allows me to share a lot of strength, it also gives me a lot of support and strength too.
Great. Priscilla, do you mind sharing with us your take on advocacy? Because I know you're a fierce advocate for families.
Sure. So my take on advocacy is that you are your best advocate. Everyone living with the condition and families who are impacted by the condition, we all just want to have a better quality of life, and we want to impact our community and impact the world we live in. And so by being an advocate, you can not only impact your community, but you can also bring knowledge to those who might have a stigma around the condition. Additionally, like Kate mentioned, there are families out there who don't speak English, who are immigrants, who are dealing with this condition that is very foreign to them. Your ability to advocate for their needs not only opens their minds and removes the stigmas that they might have about the condition, but it also allows them an opportunity to get involved in the community and to help make a change. I really believe that people living with epilepsy, we are superheroes because we get up every day and no matter what the condition brings, we keep pushing and fighting to be an avid member of society and to contribute to society. And what I found by being an advocate in this community, there are so many amazing people in our community creating new avenues, creating technology, literally fighting to make our world a better place. And I am always so happy to contribute the little bit that I can to help make, you know, everybody's life a little bit better. I am so happy to be working at the foundation because it really has opened up my eyes a lot to see the kind of impact that we can make and understanding that this condition is always evolving. Everyone has a stake in it and everyone can make a change in how we treat and how we deal with the condition in our society. So that's why I'm happy to advocate for patients and families living with epilepsy.
Thanks so much. Well, I want to thank you both again for being here, but also for all you do and for sharing your journeys and your insights. You really have made it easy to understand how engaging a strong team, finding support, resources, and arming yourself with knowledge can be so helpful that each person or each family is at the center of their journey. And so I'd like to share with everyone some of the resources and supports that are available, beginning with the Epilepsy Foundation Wellness Institute, which can help you to focus on many different aspects of living with epilepsy. And to read more about the offerings from the Wellness Institute, visit epilepsy.com. I also want to make people aware of the Managing Epilepsy Well Network, which partners with the Epilepsy Foundation to provide support to people with self-management programs that can help you to take control of your health, manage various aspects of your epilepsy, and help you to live a full and active life. I also want to share with you the SUDEP Institute at the Epilepsy Foundation as a resource. To learn more about SUDEP and to lower your risk from seizures, the SUDEP Institute can help to provide you with education and support. So we've given you a lot of information tonight. If you're still thinking you have more to learn, there's always more to learn about epilepsy. Where can you find out more? We encourage everyone to take the time to speak with your physician or nurse. Ask the questions, ask the hard questions, the questions that matter to you. You can visit epilepsy.com. You can call the Epilepsy Foundation 24/7 helpline, 24 hours a day, 7 days a week. An information specialist will answer your call and do the best to point you towards the resources and supports that you need. We also want to encourage everyone to contact their local Epilepsy Foundation office. They can help you to get to the right epilepsy care close to home. They offer resources and supports and programs and services. And they offer a community of caring individuals who will help to lift you up and walk with you along your epilepsy journey. So at this time, I want to thank all of you who've joined us this evening for your attention, for your interest, for being part of our learning community. We thank you for joining us. We hope you'll reach out to the Epilepsy Foundation through epilepsy.com and the helpline and your local Epilepsy Foundation offices. I'd like to take this opportunity to again thank Kate Cooper, Priscilla Kobe, and Allison Kukla for joining us this evening and for helping to educate everyone. And I hope you'll join the Epilepsy Foundation again as we meet to share education with the epilepsy community.